We present a case of bilateral sphenopalatine artery embolization for intractable epistaxis. A 41-year-old female with biventricular assist devices for congestive heart failure is admitted to the cardiology service. She is on aspirin and Coumadin and has intractable epistaxis. She has required several units of packed red blood cells secondary to acute blood loss anemia, and conservative attempts at nasal packing by the otolaryngology service have been unsuccessful. The patient is brought to the endovascular suite. Nasal packing is placed by the ENT service. General endotracheal anesthesia is administered by the anesthesia team. The right femoral artery is punctured with ultrasound guidance over the femoral head and below the inguinal ligament. A 6 French sheath is placed using Seldinger technique. We advance an MPC catheter over a glide wire and perform a 6-vessel angiogram. We selectively catheterize the right external carotid artery. These two runs are AP and lateral projections demonstrating the selective catheterization of the external carotid artery immediately proximal to the junction of the superficial temporal artery and the internal maxillary artery. We navigate a septor 4 mm by 10 mm below microcatheter with a synchro 10 microwire into the right sphenopalatine artery. We then perform a supraselective angiogram of the right sphenopalatine artery. These two runs are AP and lateral projections demonstrating the supraselective angiogram of the right sphenopalatine artery. We then proceed with embolization of the right sphenopalatine artery. The balloon is inflated. We perform Onyx 18 embolization of the right sphenopalatine artery. The balloon is subsequently deflated and the microcatheter is removed. The procedure is repeated on the left side. This AP and lateral projection depicts onyx casting within the bilateral sphenopalatine arteries, demonstrating complete embolization of the bilateral sphenopalatine arteries. The patient was successfully extubated at the conclusion of the procedure without apparent complication. She had no further bleeding episodes. On postoperative day 7, the patient noted an anesthetic sensation on the roof of her hard palate. As depicted in this image, physical exam demonstrated the development of a necrotic appearing area on the roof of the hard palate. Palatal necrosis following sphenopalatine embolization is a rare but documented complication of sphenopalatine artery embolization. The infrequency of this is attributed to the often robust collateralization of the facial vasculature.